We're just going to raise the e-curtain on the webinar, so hopefully everyone will then be able to see the slides that are there today. Look, good afternoon everybody. My name's Barb Vernon. I'm the CEO of Children's Healthcare Australasia, and it's my pleasure to welcome you to this afternoon's webinar. Just by way of quick background for people, the CHA Children's Healthcare Australasia is a national not-for-profit with 80 paediatric services, including all of the children's hospitals and many smaller paediatric units participating as members. And the main areas of activity we pursue are helping people network with one another, benchmark and share information about best practice. So today we have the very positive opportunity to hear about the development of building the Australian Mental Health Care Classification, and we're very grateful to Jennifer Nobbs and Vanessa D'Souza for giving us their time this afternoon in talking us through that important work that's being undertaken by the Independent Hospital Pricing Authority. The presentation is really aiming to give people a bit of a feel for the work that IHPA has been doing over at least the last year or more now in this important area, and I'm pleased to say that a number of member services across Children's Healthcare Australasia have been providing some input for consideration about the influence of that classification on the provision of care for children and young people, children and adolescents. Jennifer Nobbs, who is one of our presenters today, is the Executive Director of Activity-Based Funding at the Independent Hospital Pricing Authority, which I'll call IHPA from here on in. She leads the teams responsible for developing this classification, costing and pricing functions of IHPA, as well as the data acquisition activities. And she joined IHPA from the New South Wales Health System, where she was the Senior Advisor to New South Wales Minister for Mental Health and Healthy Lifestyles. And we're also joined this afternoon by Vanessa D'Souza, who is the Acting Director of Mental Health Care at IHPA. She leads the team responsible for developing the new classification on mental health services and has a background in community health, mental health promotion, among other things. Vanessa has worked as the Youth Mental Health Officer for a number of years at the Transcultural Mental Health Centre and on Health Promotion Officer at the High Street Youth Health Service, so she's familiar with child and adolescent health and mental health issues. So look, just before I hand over to the two of you, and Kelly will get your slides up now, I just wanted to let everybody know that this webinar is being recorded. And we do that so that many of our members who may get caught up in clinical activity at the time of the webinar occurring are able to access a podcast. So thank you to Vanessa and Jennifer for agreeing to allow us to record this session. So we've put the webinar into listen-only mode, which means those of you that have dialed in on teleconference or might be listening over the computer, we can't actually then hear the background noise, so it makes it easier for everyone to hear the presenters. But we would certainly love your participation in the discussion, and you can join the discussion by asking a question or making a comment by typing into the bottom left-hand box on your screen, and I will certainly keep an eye on that space and alert Jennifer and Vanessa to any questions or comments you may have. And I'm sure they would be happy to respond. Jennifer, are you going to be walking us through first?
Yes, I will. Thank you very much.
Excellent. Well, thank you so much.
Great, and thank you, and thanks everybody for connecting with this webinar. It's a great opportunity to talk to you all about the work we've been doing in developing the mental health classification. Vanessa and I are here at the IHPA offices, and what we're going to do is talk you through the process that we've undertaken so far to develop the classification, and then what it looks like in its current version, and then some work we'll be undertaking in the new year to improve it somewhat, because it's a long journey to get to something that I think everybody will be happy with. But first of all, I might take you through a little bit about IHPA and IHPA's work and how we work in the first place, just so you understand some context. But importantly, this is a piece of work that we're trying to achieve something really important with. The goal of all of our work is in the health sector is to improve health outcomes, and IHPA contributes through this in terms of work with data. So in this particular area, what we really want to do is help improve mental health outcomes for Australians. And how we can play a part in that is by ensuring more sustainable services and transparent decision making. Now, we're not a service provider, nor do we set the policy or the service design, but what we can do is contribute to all of that by designing a system to better describe how mental health care is provided and what it costs. And what that means is that we can put decisions back into the hands of service providers, whether at the local, regional, jurisdictional level, by providing a more complete picture of what happens within your services and the opportunity to make better decisions about that. So that's really where we're coming from with this piece of work. But more broadly, this is a new space for IHPA in terms of mental health care, but you may have heard of us in our work through activity-based funding. So IHPA's broad remit is to set the national efficient price for activity-based funding, and that's used to determine Commonwealth funding to local hospital networks for the activity provided. And really that's an awful lot of complex work, looking at cost data and activity data and working with technical groups and clinicians to develop a way to ensure that costing and classifying and pricing is correct and robust for broader health services. For those health services that don't provide enough data for us to be able to do that, we set criteria for defining block-funded services and a national efficient cost for this. Now, with this guidance, we're setting a price which determines the Commonwealth growth funding for health services. States and territories have flexibility to contribute above or below that amount. So that funding that exists isn't exactly what's provided to a service. It's a larger amount of funding and gives you flexibility at the local level to adjust to the needs of your services. So what's really important to note is that states and territories determine the volume and the distribution of services, not IHPA, and we don't handle cash, nor do we get involved in evaluating performance or determining where services go. So a bit of background there to our work, but we've not been able to do a huge amount of that in mental health care because the way that we classify services, the way that we understand and describe what happens at a patient or consumer level is there for the rest of healthcare services where there's good data sources with consistent reporting at the national level, but it's not there for mental health. In the community, it's really been too hard so far to collect meaningful data at a consumer level. And in the admitted setting, we've been able to fall back on an existing system called diagnosis-related groups, which, when modified, can provide some detail and provide a reasonably accurate description of the costs associated with services. But of course, diagnosis is really not the most important thing in mental health care, and two people with schizophrenia have very, very different needs or might be at very, very different stages in their recovery and their care. So relying on diagnosis only, which is the way that we broadly classify health services in hospitals, has just not been good enough for mental health care. So we've had some interim arrangements for the past few years, but IHPA has been committed to developing a better way of explaining what happens to people with a mental health issue in terms of the care that's provided through the public healthcare system and might be provided outside of that system in a way that's meaningful, that includes considerations of outcomes and looks beyond the label of diagnosis. So at the moment, we fund services reasonably well, but not particularly helpfully, based on diagnosis in the admitted setting. We block fund in the non-admitted setting, and the emergency department has a whole different system for which mental health is part of, but deals with issues on an urgency basis. I mean, it's out of scope for this work. So over the past 3 years now, we've been working to develop a new way of classifying mental health care services. Importantly, whilst our work is linked to activity-based funding, we wanted to develop something that has much broader use and a remit, so other people can pick up a classification and use it for other purposes. And we wanted to develop something that provides a way of describing the factors that inform the types and costs of mental health care, So that's not just about diagnosis or drugs. It's about how an individual is going in life, and the intensity of care that needs to be provided to them, and how their outcomes may or may not be improving over time. And something that supports new models of care. So it doesn't segregate between the admitted setting and risk incentivizing care in the admitted setting, but enables care to flow from the community to the admitted setting where needed and back into the community. And it provides a rich source of data that can help you make better decisions about things in the future, informed by patient level, by consumer level data. And it's pretty broad. It includes all services where specialist mental health care is provided. So we've been working on this for the past few years through our mental health working group, with the goal really, and I'll just show you the next slide, of being able to differentiate between two individuals with mental health care needs. So on the face of it, you might see two men in their 40s with schizophrenia, and that's all you might know about them, and you might lump them into the same category. But we want to just delve below that to look at the things that might really, really drive the care and the support that they need. So as I mentioned, we have a working group of members that provides us with advice on this, and flashing up in front of you on the screen, you'll see all of the different organisations that meet on a regular basis to guide this work. So that includes jurisdictions, technical advisors, clinicians, through to Mental Health Australia and consumer and carer reps. So they've been guiding our work over the past few years, and we've been working towards developing a classification. Now, we thought we'd just run through the steps involved in developing a classification, because it's a piece of work that's unusual outside of IHPA's world. So really, there are 6 steps to developing the classification: defining the services, identifying what the cost drivers might be, then you test those through a costing study, and then using all of that data, you work to develop a classification. And then comes the really hard part, and that's the bit that we're at the moment. So once you've got a draft classification out there, and we released ours just about a week ago, you start to test it and test it and test it and refine it. And the real work comes when you can start to collect data on a national level, which means that you get enough data that you can really start to go through it and see what changes might need to be made. And you can get feedback from clinicians and other groups in the community, from consumers and carers about how it's working. So to take you through those steps that we've been undertaking, I might just pass over to Vanessa, our Director of Mental Health Care.
Thank you, Jennifer. Hi, everyone. So the first step that we had to do was to establish which services would be in scope. And in order to do that, we commissioned the University of Queensland, and with considerable consultation with the sector and various experts and clinicians within the field, we developed over a period of time the definition you can see on your screen. So mental health care is care in which the primary clinical purpose or treatment goal is improvement in the symptoms and or psychosocial, environmental and physical functioning related to a patient's mental disorder. Mental health care is delivered under the management of or regularly informed by a clinician with specialised expertise in mental health, is evidenced by an individualised formal mental health assessment and the implementation of a documented mental health plan, and may include significant psychosocial components, including family and carer support. So it's a broad definition that we developed that had a lot of clinical input, and that gave us the starting point from which we then moved to the second step, which was we needed to identify potential new cost drivers. And that was a project that University of Queensland was also commissioned to do, which was to look at the data that we already had, but to also consider whether or not we could look at other cost drivers. So cost drivers were identified relating to perhaps the phase of care. So what was the prospective goal of care? Where was that consumer or client moving to? Perhaps the recent episode of mental health care, the types of interventions that had been delivered, and also outcome measures using the National Outcomes and Case Mix Collection, or NOC, That was also used to consider factors that might impact on a patient's or client's social functioning. During our public consultation phase 1 or paper 1, which was conducted in January 2015, we received a lot of valuable feedback and consideration from child and adolescent mental health services. And I think if you're on the other end of the line and you did contribute to that, we do thank you for your time and effort in providing us with that detail in your submission. The 4 points that are up there on the screen at the moment are only a brief summary of the issues that were raised. But in a nutshell, there were questions about the use of, for example, the NOC and whether or not for some target groups it might be out of scope, for example, paediatric mental health. Secondly, family functioning and other support, so looking at an individual's housing arrangements, employment status of their family and the levels of their family support. Thirdly, the impacts of education and child services, so involvement of care and protection or juvenile justice. Also other issues such as abuse, neglect, trauma, physical and intellectual disability or impairment, cultural issues, homelessness, obesity, substance use and poor social networks. And we also were asked to consider whether or not having a single person focus was really applicable for child and adolescent treatment practices. For example, the sector said that the involvement of families and care providers as well as educators was incredibly pivotal to the successful outcomes for a young person. The pilot also helped us to, move to step 3, Step 3 was the mental health costing study, and that was undertaken across Australia at 26 sites. We thank those who are on the other end of the line who have been involved and who have contributed an incredible amount of time and effort to help us develop perhaps one of the largest data sets we do have of mental health service delivery across Australia. Much of the data that we do have at the moment is of a poor quality, and so the mental health costing study was a means by which we could collect data, ask key questions about the cost drivers that we thought might be issues that we raised before about interventions and phase of care, as well as outcome measures, and then have a look at whether or not there was any validity in those claims. The next step we did, using the data from the classification and guided by our expert reference group, and their names are up on the slide in front of you, and they are a background of clinical and technical experts. We then worked on multiple, if not several million different types of variables and data modelling preparations that used the mental health costing study and came up with the classification, and I make it sound very simple, but it hasn't been, for the classification that is in the public consultation paper that is being circulated at the moment for your feedback.
Vanessa, can I just interrupt you for one moment? We've got a couple of comments there from participants. One of the questions, and I was wondering the same thing. So on your slide where you showed all those services, 26 sites across Australia, how many of those were child and adolescent mental health sites that contributed to your evaluation of the costs?
Yes, so it's Jennifer here. We had the Children's Hospital at Westmead. I'm noting there's some queries around that on there. We had a number of specialist units, but not a specialist paediatric hospital that were peppered around the country. I'm happy to provide a list of those out of session at this group, and we'll also have a full report on that that's made public early in the new year. We tried to get some more specialist paediatric services because we know they tend to be higher cost, but we're limited to the Children's Hospital at Westmead. But we went to great efforts to ensure that across the admitted and community sites we picked up child and adolescent admitted and community mental health teams.
Thanks, Jennifer. So you were right, Malini did say that at the Westmead Hospital there was some issues, I guess, around their data collection, and that the clinicians felt that there hadn't been the measures that were actually generated hadn't been, as closely aligned to clinical practice as might have been ideal. Was there a process used to try and identify how best you said the data systems were poor that you were needing to work with at first. I presume there'll be quite a bit of development of data systems once the classification is actually finalised. They're sort of chicken and egg questions, aren't they?
Yes, yes. So I can't comment on the Westmead issue that was raised. That's really a state matter, and I'm not too sure about what discussions were had there. Data collection for mental health has never been particularly good compared to the broader health care system nationally. I think that's reasonably well known. What we found more broadly outside of mental health care was that when activity-based funding was implemented and linked to national funding, improvements in data collection increased exponentially. The moment that you link money with something, you get significant change. And so we found that that's been something of an incentive for improved data collection. There's obviously a whole lot of work in terms of implementing the classification, and when Vanessa comes to talk about the classification itself in terms of adjusting data collection systems and data reporting systems, we've been working with states and territories over the last couple of years now to identify what those issues are. Ultimately, it's a state responsibility to make those changes, but we're trying to assist in the best way that we can.
Thanks, Jennifer. Sorry to interrupt you, Vanessa.
That's all right. No, that's fine. So moving on, after the development of the classification, sorry, next slide, to the here we go. The classification, the structure that was developed in consultation with the expert reference group and the mental health working group has 6 structures or levels within the admitted setting. They are that there's the phase of care, of which there are 5, so assessment only stands alone. Then there's acute, and then functional gain, intensive extended, and consolidating gain. There's also space to be able to collect unknown phases, which may be that they haven't been completed by the clinician, and we expect that they won't need to be collected, that as people's experience and exposure with the classification improves, that the number of unknown phases will be less, but it's just there as a catch-all for those that during the process. The next level is age group, and at the moment it's broken at quite high level of 0 to 17, 18 to 64 and 65 plus, and that's largely based on the advice we received about the outcome measures tools, and we are aware that, for example, there's a huge difference between 0 to 17-year-olds, let alone between 18 to 64-year-olds, and that we see that within future iterations of the classification that those age groups may be refined to better distinguish between the different social, developmental and psychological needs of those different age groups. So at this point in time, this is what we're starting with, and it's a place where we have to begin because this work hasn't been done before, and we don't have any data to pin anything on, so this is a means by which we can start, and over the years we will be refining to the point where your valuable feedback will help us to get the classification to a point where it better meets the needs of every single person who goes through needing mental health care within Australia. The next level in the admitted setting is mental health legal status. The data demonstrated a strong relationship with the 18 to 64-year-old age group, and that doesn't mean to say that it wouldn't affect any of the other age groups. Again, it just is that premise of this is a starting point. We're basing it on where the data was strongest in the mental health costing study, and future iterations may see a change within that to other age groups and or to other settings. HONOS complexity is the next level down, using the tools that are most within line of the age groups that are being described. So HONOSCA for the 0 to 17, so 18 to 64 is using HONOS, and the HONOS 65 plus the 65 years and over. It results in a total N-class capture of 45 N-classes, and then within the community setting, it's quite similar. You'll see the same levels are there. The only difference you will note is the fact that the LSP16 has been included beyond HONOS. So the one extra level that it is in there. And that is because the data demonstrated that there was validity in including it. And again, my original point of this is a beginning, this is a starting point. And at this point, we don't have enough data to put it across all the other settings. But as people out there are collecting the data, and we're able to start refining what we do know about what's being delivered, so will the classification. So at the end, the total number of in-classes is 46 within the community setting, noting that there is no mental health legal status because obviously community treatment orders are a different issue, and there are, I guess, different states legislation that impacts on the applicability and business rules relating to community treatment orders.
So I might just jump in there just with one issue. The decision trees that you're seeing there are not decision trees that clinicians need to make. So it's not a question of asking what phase, what age, what HONOS complexity. This is about really one additional item to be tagged onto your current work, and that's phase of care. So that needs to be a clinician-rated tool. So a clinician needs to make a decision about what phase of care somebody is in, which is the prospective goal of care. And that's the only other addition. The other issues are collected already, and the work on those happens behind the scenes. So a grouping system, which is a way that classification collects data and sorts it, operates behind the scenes of your normal data collection system to filter consumers through this process and decide which end class they end up in.
So in order to, thanks for that, Jennifer, in order to ascertain the performance of the classification, we have to collect data in the first instance. And we do know that by collecting the data that we're expecting there to be improvements over time with the classification, as I said before. Not only will we be able to collect a larger volume of activity and cost data that will come through as a result of the new Australian Mental Health Care Classification, but also there'll be key improvements in capturing key variables such as the outcome measures tools, as well as mental health legal status and age. The other benefit is that we'll also see an improvement and clarity in the phase of care definitions and business rules. So as we receive feedback each year as we review the classification, we'll be able to take your feedback to be able to change the business rules and definitions so that they better meet the needs of your clinicians, as well as technical people that might be implementing it. I can't read.
Just noticed a question that's come up. We can just deal with this one quickly. What does LSP stand for? You're forgiven for not knowing this because it only applies to adult consumers. It's the life skills profile. It's outcomes measure that's used for adults in the community to measure their levels of functioning.
Thanks, Jennifer. So the step we're at the moment is along the arrow that Jennifer had started off with, is we're currently at the testing point. We are nearly there in getting a classification that is ready for use. There is a best efforts collection happening at the moment in 2015-16, but where we're at the moment is actually a pilot, and there are 4 pilot sites nationally that are taken on board the draft business rules and resources, training and definitions that we've developed in order to aid the implementation from 1st of July 2016. So we're trying it at 4 sites, both we've got New South Wales, South Australia, Queensland and Tassie, and those sites are helping us to define what it is that we need to put in our training modules, what it is that we need to, how is that we need to define mental health phase of care, what are some of the tools that might assist the clinician, so lanyards, fact sheets, and all of that feedback is incredibly valuable because at the end of the data collection period, which will be later this month, that we will be able to see what it is that people have taken away from the pilot and what are the areas that we need to develop and refine in order to roll out the classification from 1st of July next year.
Excuse me, Vanessa, it's Barb here again. I think this next comment that's just appeared is, or this question is related to the discussion that you just gave, or the clarification you just gave, Jennifer, about the life skills. The question asks whether the strengths and difficulty questionnaire that's used for child and adolescent ambulatory patients is able to be considered, or is potentially relevant to ABS funding?
Yes, certainly. So it's Jennifer here. We collected all of the NOC measures throughout the costing study. So those that appear in the classification are only a small part of it all. And we found that the Strengths and Difficulties Questionnaire and CGAF weren't well populated enough for us to do any meaningful data analysis on. Now, that's not to say that they're not useful and they might not appear in the classification in the future, but we couldn't do enough with them at that time. So as they're NOC measures, they will continue to be collected, and we're doing some work with AMHCCC at the moment to ensure a more simple process and consistency between the NOC and the mental health classification. We'll be able to continue to monitor those, and if we find that that provides an important indicator of variation in costs, we can certainly include it in the classification in the future.
Thanks, Jennifer. And Wade from Western Australia is asking, is there any reason why there's not a specialist child and adolescent site included in the current costing pilot, and is there perhaps an opportunity for one to get involved?
We went to all jurisdictions and asked them to nominate sites for the pilot, and unfortunately no child and adolescent sites were nominated. It's a shame, but we've also tried to, the costing study was more significant than the pilot in terms of collecting data, because we collected a lot of cost data and that informed the development of the classification. The pilot is really about testing an awful lot of materials, so there's capacity to test those for the child and adolescent sector as well outside of the pilot. And we've certainly got some work planned with the sector more broadly in the new year, so we can try and address that. There are child and adolescent services at West Moreton, but it's not a specialist facility in the way that I assume Wade is thinking of. So you need to lobby your jurisdiction state reps if you think something else is in there, but we're really reliant on state support for these programs.
So thank you, Jennifer, for that offer of doing some further work next year. I'm sure there would be interest across the CHA membership in looking at some of that material, even if it's outside the pilot process, because there's a lot of interest in the development of the classification and ensuring that it provides a robust and relevant tool for the child and adolescent mental health sector as well as for the adult mental health sector.
Great. So where we're up to at the moment is that we have a public consultation paper that's out in the public since 10th of November. It was released, and it closes on the 18th of December. And we encourage you to consider putting in a submission. The submission will allow us to further refine the classification, and if not for the rollout from 1st of July, then for future iterations. This is part of a long-term body of work, and we need the clinical input and your specialist expertise to be able to help lead us in those directions that are most applicable for the setting and the sector. The other ongoing work that we'll do is just ongoing refinement and consultation to produce what will happen for the 1st of July 2016, and that will be the official version 1. So at the moment, the draft version 1 is out with the consultation paper. Lastly, areas for development, and as Barbie just pointed out, that it's great if we could get some support and feedback from the child and adolescent mental health sector. That is one of our big priorities for this coming year. We would like to engage with the sector to conduct clinical reviews, to sit down and have future conversations and discussions about some of the key topics. I know, for example, from one of the pilot sites at West Moreton that they asked about the applicability of phase of care and how does it work within a child and adolescent setting. And for us to understand what some of those barriers might be, we need to hear from you as service providers and clinicians. The other areas that we want to work on are older persons, because the mental health costing study didn't have such a big pool of data for that age group. And we also want to consider residential. So originally we had planned to, but the data was limited in what we were able to obtain. And largely that was probably more to do with how people define the services that they delivered rather than actual residential services not being included. They were included, it's just that they were perhaps defined differently across jurisdictions. And lastly, the thing that we want to do is to further refine the definitions and business rules associated with mental health phase of care. We hope to conduct 1 or 2 phases of an inter-rater reliability study, which will, in the first phase, look at clinicians looking at case vignettes to help establish whether or not they would have picked the same phase of care that a consumer might have been in. And then secondly, with ethics permission to be able to look at that next stage of having real-life cases where a clinician might be able to sit in and help us define whether or not they would have picked phase of care change being at the same time as another clinician.
Just a few things to keep you busy then, Vanessa.
Yes, just a few things. I mean, and it's really exciting because the potential for involving such a great variety of service providers is immense. So we've got community sector as well. I didn't mention them, but they provide a lot of mental health services. And yet at the moment, as one of the first slides that Jennifer talked about, we are wanting to look beyond the scope of activity-based funding because we see merit in a service delivery or that is not derived by who funds it, but more about the patient journey. So one of the pieces of work that we need to do is to look at the fact that this is just a starting point. This is just the beginning of a long journey of which we hope you will accompany us on. That the ARDRGs within the admitted setting, they're now at version 8, and we hope that with your feedback, with our constant nagging of you, consultation, but also looking at the data that is being supplied, that we'll be able to continue refine and the classification, and to be able to have a classification that better meets the needs of services as well as consumers. So we will continue to formally consult, we will continue to formally feedback the data that we have received from you and to ask questions. So the last, oh sorry, Barbara?
I was just going to say, Wade has asked a question here about if you're able to share more information about the definitions in relation to phases of care. I presume that's in the consultation paper, is it?
It is. There's a link, and I didn't bring a printout of it, but there are, if we go back a few slides, maybe to the structure. So the phases are the same in admitted and community. There are 5 phases, and I mentioned before that there's assessment only, and that's so that when a consumer is entering a service, their needs are taken down in one time only, and they don't need to replicate the story. There are 4 other phases, and the next one is acute. So that is where a consumer may have quite high intense needs, requiring, and sometimes it's also indicative of the setting that they're in, whereas the next 3 are probably more rehabilitation-like phases where, depending on where the individual is within their journey, that they might be, for example, able to receive some support from a community organisation, but then have weekly appointments with their psychiatrist. I've just got Alison's going to pass me the fact sheet that we've promoted. Thank you.
So there's a lot more information about this in the consultation paper, some detail, and we're working through the definitions at the moment in a pilot. So we did some work around this, and any of you who are involved in the costing study knew that this was a very painful process, trying to work out where a consumer should fit into one phase of care. And I just want to raise that we're trying to address that, and we've got some good anecdotal feedback from the pilot in the first place. So we've refined the definitions a bit and given some examples, and perhaps some work that we can do with the child and adolescent sector in the future is to work out some test with you some examples in relation to child and adolescent care to make sure that they sit well with our descriptions. I think it would be useful for that process, but you can see more detailed descriptions in the consultation paper.
Thanks, Jennifer. I'll just give people a chance to think about some further questions they may have. Did you have more you wanted to say first, Vanessa?
No, only just how to get involved. On our last slide, we've actually got details of not only our website, but then there's also our Twitter account. We're also on LinkedIn. Importantly, that the consultation process closes on the 18th of December. and that you will have a mental health working group representative that you might want to liaise with from that original list that we talked about. And there are our contact details. So we encourage you either through a submission or through directly liaising with us, probably, and I don't want to jump on Jennifer here, but just maybe direct it to me because I know Jennifer's very busy. And I will happily field your questions and perhaps pull them and be able to respond in a group way. I'm just looking, there's some questions coming up. Which one have we done?
So Wade has asked if you can explain the concept of RIV.
Okay, sure. Would you like me to have a go at this? So RIV is a reduction in deviance reduction in variance. There's a RID and a RIV, and this is a statistical technique for explaining the statistical fit of a model. So at a very basic level, the closer to 100%, the more accurate a model is. You don't actually want anything to get to 100% because there's all sorts of issues associated with that. But the higher the percentage, the more accurately the model describes what's happening. What you'll see is what we would consider good RIV scores for the classification in the consultation paper for a draft classification. We would want to see these scores improve significantly over coming years. This is a good measure of an early version of a classification, but we'd like to see some leaps and bounds in future years. And I'm pretty confident we can get there once we start to get some national data collection going and we can really start to work with a very large data set and, of course, really important feedback from the mental health sector about how things are working and how they aren't to improve those scores. I hope that's of help.
Thank you. Thank you, Jennifer. Look, I've pasted in the address for the just one page short of the one that you've given on the slide so that people have got some of that background information, and it's easier for participants to copy and paste a link out of that text box. But look, I was interested, it's encouraging to see the split of ages, recognising that there may well be some different factors involved in providing care to someone in the sort of 65-year-old age category from a 0 to 17-year-old age category, for example. I just wondered if you could speak briefly to how it was that those three age splits have been identified and how you anticipate that they might inform funding and other decisions moving forward once the classification is finalised.
Yes, so these splits were purely practical. They align with the different NOC measures that are used at the moment. So it enabled the split from the from HONOSCA, for example, and the range of other child and adolescent measures right through to the older persons ones. So it's likely that those splits at those points will continue to exist for that reason, but there of course may be more within each group itself. There's no significant issue in relation to funding in terms of it. We don't, those are splits in the classification as are all others. We're simply interested in the cost, the final cost at the end class of each. We don't make any policy decisions on the basis of that. At the moment, we don't have enough data to split any further, but I know that it's one of the things in a few years' time, once we've got a fair bit more data through national collection, that we'll be having a look at to see where more splits may be.
Thank you, because I'm aware certainly within the child and adolescent space that there is also recognition of substantial differences in care between, you know, a 3-year-old and a 16-year-old, and obviously classifications have to be ways of combining up groups, different populations of people into a meaningful structure. But there's also, you know, some important clinical differences, I guess, for people involved in providing that care. I just wondered also, oh look, here we have a question, sorry. Govind actually has asked whether we can have a copy of the slides. Would you be happy, Jennifer and Vanessa, for us to send a PDF version of the slides to the participants today?
Sure, that's a great idea.
Thank you. And Malini has said, can we confirm that until IHPA finalises the phase of care, New South Wales State will use principal services category for the 16-17 NWAR?
Yes, so I'm not familiar with the principal service category. I think that's a New South Wales term. The phases of care have been finalised. The classification is being implemented for best efforts collection in 15, 16, 16, 17. What I think this question might be getting at is when it becomes applicable for funding, and that's from 1st of July 2017 onwards. So New South Wales will be reporting data on a best efforts collection up till then, but it won't be linked to funding.
Okay, so there's a little bit of time for some further consideration of this framework. Certainly we would welcome input to a CHA submission that we'll make to IHPA from any of you that are online and would like to share the priorities and comments of your service with us. And we very much appreciate IHPA being so open and consultative in the development of these processes. I think they've actually been, on a wide range of issues, very receptive to input from the child and adolescent health sectors in general and the mental health sector as well. I wanted to just go back to one of your early slides. I think, Jennifer, when you were still talking, you listed some of the feedback that had been gained from the child and adolescent health sector, and particularly a comment that had been reiterated, I think, I'm sure, across services about the centrality of providing care to families, to parents and carers and siblings, as rather than just to an individual child, because certainly the clinicians have educated me over the years that it's almost meaningless to treat a child in isolation from their family context. How has that kind of thinking been discussed and considered in the development of a classification, and how do you anticipate that there might be opportunities to explore funding models that may support more effectively that effort?
Absolutely. So yes, you're right. We've had quite a bit of feedback from the sector on this. I think it's probably worth just explaining how we go about attributing costs in the first place. So what we're not doing is setting up a framework for how you provide care. We're not specifying any of that, and this is supposed to recognise there may be variations in providing care, but broad costing across the services will be attributed to the patient. What's really important to note is that with the costing systems that operate nationally, all costs have to be linked back to the individual patient or consumer. So those costs will be both those directly employed in provision of care to that person. So at a very, very simple level, that might be some medication, you know, or psychiatrist, psychologist time. But we recognise all of the costs across the service. So that includes food, electricity, you know, all of those things that involve with running a service of any sort. And some of those can be directly attributed to the patient, and some others are modelled so that they're spread across the system. So something doesn't need to actually happen to an individual for the cost to be attributed to that individual. If a mental health service is spending a certain amount of money treating a group of clients, all of that funding has to in some way be apportioned back to those clients. The classification does not specify how that happens. There's a range of different standards that apply across the health system in terms of how costing happens. So if a clinician is providing support to a family member and those costs are recognised in the system, so it's really important that those costs are somehow recognised in your system at a local level, then that feeds back into the way that we understand the costs associated and then feeds back into the activity-based funding model. So a lot of the responsibility for this lies at a local level in making sure that everything that you do is recorded in a system so that costs can be attributed across the board and things aren't missed out. What we don't do is say only those things that you have reported will be captured, because if the cost is there in the system, it has to be attributed to something. So I hope that picks up a bit. We do have some data collection items in terms of family support through national data set specifications, and outside of the child and adolescent sector, this has obviously been an area which a number of groups have really wanted us to pick up in the classification. We're really open to that, but even with intense encouragement of sites to report data through the mental health costing study, we found some of the standard data items about family and carer support were really poorly collected. And so we can only start to recognise those once collection improves.
Thanks, Jennifer. I'll come next to Melini's comment, where there's an interest in understanding if the HANOSCA would be a key item for calculation of NWAR in the future.
So the HANOSCA is included in the classification system at the moment, and it's a key element of the classification. It doesn't directly link to the NWAR, but the way that the HANOSCA, and in fact all of the outcome measures that are in there, play into this is that, as Vanessa was explaining earlier, clinician undertakes the measure as usual, and then behind the scenes there's a weighting system provided, allocated to each question, with a higher weighting for those questions, for those areas of an individual that might suggest that there's more cost associated with them. The scores are then totaled up using the weighted scores, and then it's split by moderate or high cost to determine the end classification. So it's not directly related to the NWAR, but it's an important factor in the classification.
And just for a point of clarification, Melini, I'm not a clinician either. What does HANOSCA actually stand for? Is that a classification acronym,
No,
or?
It's an outcome measure. So HONOS, which is a widely used mental health outcome rating tool, is the Health of the Nation outcome scale, and then the HANOSCA simply adds child and adolescent on the end. So there's a widely rated outcome measure that asks a lot of questions about an individual, and then there's a specialist one for the child and adolescent consumers, and then another one for older persons, that's the 65 plus.
Beautiful, thank you. And Wade was following on from our earlier conversation in discussing the role of families, parents and carers, and really alerting us to the fact that it's not just as a support role, that there can be specialist treatment for parents and carers that's involved in actually helping a child address a mental health issue. Would that mean that they would be regarded as a separate patient under the adult part of the classification? Is that how that would work?
If the service categorises them as a patient, so we don't make those decisions about who would be a patient or not, but if there were another name in the system that was a patient, then the cost would be attributed to them. And
so children's hospitals don't have adults as patients is, I guess, one of the constraining factors here. They would have the child as a patient and perhaps be providing specialist care to the parent or carer.
So the cost associated with providing that specialist care would be attributed to the child. And so that's why you might see, one of the reasons why you might see higher costs of care in specialist paediatric services. And so that's why it was important that we got some of that in there. IHPA's pricing model also includes an extra loading for paediatric patients as well. So the increased cost of providing care to that group is recognised through our pricing model.
Thank you, and we've got probably time for one or two more questions if people have them. And while you're thinking of those, I just have a last one for you, Jennifer and Vanessa. It seems quite encouraging that the structure of the community and the acute frameworks are very similar, and you mentioned that the intention is to support more the journey of the patient than the location of the care. Do you see opportunities in progressing the classification in that way to improve harmonisation between different funding sources so that there can actually be more joined up services for children and young people?
I can answer part of that question through the work that we're doing. Yes, we would like to connect these up. The reason that you're not seeing one big decision tree at the moment is because there are not unique patient identifiers across services nationally. So we can't always link the individual moving from one setting to another. But when that time comes, when everybody's able to include that into their data collection systems, the mental health classification stands ready to incorporate that, so we can have a better flow of understanding of individuals through the healthcare system. Of course, you're talking about something a lot more, about all of the care needs of an individual, and I assume you're referring to the education sector, community services, and those sorts of things. This is so IHPA works within the healthcare space, and our legislation limits the work that we can do outside of that. So this is specifically for the healthcare sector, and we can't go beyond that as requirements of our legislation. But we are very aware of how integrated the services are, particularly for child and adolescents. So more broadly, we've been doing some work with the NDIA to make sure that they're informed of our work. So if there are synergies that can happen between the NDIA and the mental health classification, they can be best taken advantage of. I can't say whether we could merge this with other areas in the future. I think that's a few years away, and it's certainly outside of our remit at the moment. But any work that that provides a better description of what happens to an individual is obviously incredibly useful, and whether that's at a normal level or whether that's normal sort of day-to-day functioning level, or whether that's in a research capacity, there's definitely opportunities in the future.
Thank you, Jennifer. Sue's just asked for a quick point of information. There is actually a slide in the collections here that's got some advice on the individuals that are contributing advice on the advisory committee. Is that on your website, Jennifer?
Yes, it is. Under the mental health page, you'll see, if you scroll down, you'll see a link to the mental health working group members.
No worries.
I don't think it lists the actual individuals, but if anybody wants to get in contact to find out who that might be, then they're more than welcome to contact Vanessa or I.
Thank you so much. Look, we're out of time for today, but we're very grateful to you for providing us with an overview of the work you've done today. It's an important body of work, and as you were saying, Vanessa, it's the first step, really, the first big step in a longer journey. I'm sure in 10 years' time we'll look back at this work and realise how pioneering it is. But I really want to thank both of you. I know it's a very busy time of year with the work that IHPA has on its plate at the moment, so we're very grateful to you for making time to provide this information to everyone and for allowing us to share this with other people who were interested. We had more than 70 people register, and people then get caught up on the day, so they'll now be able to access this recording as well. So thank you, both of you. Did you have any final remarks that you wanted to share?
I think just really to say thank you very much. It's been a really great opportunity to engage with a sector like this, and thank you to everybody who's joined the conversation today. It's great to see people interested in this work, and I'm very grateful for your contribution so far, and I look forward to seeing some advice through our consultation process, and no doubt bumping into a few of you at various conferences. We've been talking to a number of different groups about that, and we've had some really good feedback so far.
And just lastly, that we will be sharing our webinar recording on our website and through our social channels. So if you have missed it or come in at the tail end, that's totally fine. There'll be a recording there for you.
Thank you. And a reminder to everybody that the submissions close for the current consultation on the 18th of December, and if you wanted to share your commentary and feedback with CHA, we would be happy to incorporate your points in a submission that CHA will also be making. Thank you, Jennifer, Nobs and Vanessa D'Souza very much for your time. Good afternoon, everybody. Have a great day.